What if I told you that the most critical medical intervention you're ever going to perform on a 150-pound, highly reactive dog actually happens when it's like an 8-week-old, 4-pound puppy?
Yeah, it sounds crazy, but it's completely true.
Right. Because picture this. You're standing in your clinic, the stainless steel exam table is gleaming, the overhead lights are humming, and sitting right there in front of you is a tiny, wide-eyed Siamese kitten or, a squirming golden retriever.
And the owner is just looking at you with this mix of absolute adoration for their new pet and, well, complete reliance on your expertise.
Exactly. As a vet student preparing for your clinical practice, this is the moment it all becomes real. You are stepping into the first consultation.
And I would argue it's the most pivotal 20 or 30 minutes you'll spend with that animal and that client. I mean, this isn't just a basic wellness check where you clear them for vaccines and hand out a shiny rabies tag.
Yeah, it's way more than that.
Oh, absolutely. This visit sets the trajectory for that patient's entire life. You're establishing the foundational relationship between the client, the patient, and you.
Okay, let's unpack this.
Yeah.
Because looking at the sheer volume of preventive medicine, genetic screening, and behavioral psychology we have to cover today, it's clear there's a massive amount of pressure riding on this single appointment.
There really is.
We're basically running a clinical gauntlet, all while trying to maintain patient compliance and, build client trust. So what's our mission for this deep dive?
Well, today is really about understanding the architecture of that consultation using our source notes. We aren't just going to run through a checklist of the animal's body. We need to explore the physiological mechanisms behind what we're screening for.
Right, the why behind the what.
Exactly. Why each specific step matters in the overarching picture of veterinary care.
Let's jump right in then, and let's start before you even pull out your stethoscope, because before your hands are even on the animal, there's this crucial setup phase, right? It's kind of a hybrid of getting to know you first date and like a friendly detective interview.
That is a great way to put it. And timing is everything here. The ideal window for this first consultation is when the animal is about 8 to 10 weeks old.
But crucially, and I think a lot of people miss this,
Yeah.
you really want this visit to happen only after the puppy or kitten has settled at home for a few days.
Yes, that buffer period is absolutely vital. I mean, the natural instinct for a new owner is to drive straight from the breeder to the clinic.
Oh, for sure. They want to make sure the pet is healthy right away.
Right, but physiologically, it's a terrible idea. Think about the mechanism at play. When a young animal leaves its mother and litter mates, the sudden lack of familiar pheromones, plus a huge shift in environment, diet, routine, it causes a massive cortisol dump.
Wow, so they're just flooded with stress hormones.
Exactly. And if an owner brings that animal straight to your clinic, you're examining a highly stressed patient whose mucosal immunity is temporarily suppressed. Their behavioral baseline is completely skewed by panic.
You're not seeing the real puppy. You're seeing the terrified version.
Precisely. Giving them a few days to acclimate to their new home allows their endocrine system to stabilize. So when they finally see you, you're getting a much more accurate representation of their cardiovascular rate, respiratory effort, and temperament.
That makes total sense. So while they're acclimating in the exam room, you're gathering the signalment, checking the breeder's paperwork. But here's the thing I want to push on.
Sure, go ahead.
For pedigree pets, there's this huge emphasis on asking the owner about the animal's future use. Like, are they going to be a breeding animal, a working dog, a family pet? Why do we need to stress about the future career of a tiny, fluffy 8-week-old puppy right this second?
What's fascinating here is that the early baseline setting completely dictates the long-term care plans. If a client tells you this Labrador puppy is destined to be a field trial champion, your radar for orthopedic perfection has to go through the roof immediately.
Oh, because of things like hip dysplasia.
Exactly. You have to initiate discussions about breed-related health schemes, like hip scores, today. A minor laxity might be manageable for a couch potato pet, but it will absolutely devastate a working career.
Right, so you're basically reverse engineering their lifelong care plan based on their job description.
That's spot on. But the overriding goal of all of this, the history-taking, the gentle handling, is making the visit pleasurable. Because the most impactful intervention at this stage is actually psychological.
Ensuring they don't fear the clinic.
Right. If you force an aggressive restraint on a terrified puppy during their first visit, you are virtually guaranteeing that every future visit for the next 15 years will be a nightmare.
A fearful, aggressive mastiff in 5 years starts with a mishandled puppy today. Okay, so trust is established. The history is taken. Now you move smoothly into the nose-to-tail physical exam. And here, your focus shifts entirely to hunting for signs of infectious or congenital diseases, right?
Yes. You start with a global assessment of their demeanor. A healthy young patient should be alert, bold, and inquisitive. Although, some are just naturally a bit reserved.
Sure, but if they present as lethargic, completely disinterested, and reluctant to eat, your clinical alarms should be ringing.
Loudly. Lethargy is your first major red flag. From there, you're looking for highly contagious pathogens. Coughing in dogs and sneezing in cats, classic signs of infectious respiratory disease, and then, of course, diarrhea, which is super common.
Wait, let me stop you there. Isn't diarrhea in a new puppy usually just because the owner switched their kibble too fast? Like osmotic diarrhea.
You're absolutely right that rapid dietary shifts disrupt the gut microbiome. It's a very common cause. But here's the clinical nuance you have to master as a student. If the diarrhea is present at the exact time of purchase, it could heavily point toward an infectious cause.
Oh, like parasites or giardia?
Or parvovirus. You
Huh?
simply cannot afford to dismiss early onset diarrhea as just a food issue. And feline GI tracts are notoriously frustrating to treat in this regard. Their margin for dehydration is incredibly narrow.
Yeah, tiny kitten can crash so fast.
Exactly. Now, while you're assessing all this, you're also watching their gait for neurological signs. You're looking for intention tremors, ataxia, dysmetria.
And the scary part is, while these might not progress, they rarely improve.
Unfortunately, yes. It's a heavy burden, but spotting these structural brain or nerve damages early is critical for managing the owner's expectations.
Okay, so general red flags are one thing, but as you move to the head, what you consider normal completely shifts depending on the genetics of the animal sitting on the table. We're talking about breed quirks.
Right. Extreme characteristics, dwarfism, hairlessness, excessive skin folds. These built-in problems must be mentioned to the owner today.
You can't just ignore Shar-Pei's skin folds until they get infected.
Exactly. You have to be proactive. So you check the mouth for cleft palates, normal primary dentition, dental occlusion.
Maxillary prognathism, like an overbite, is a fault,
Right.
but it's rarely clinically significant unless it's traumatizing the palate, right?
Correct. The eyes, however, require meticulous attention. They must be clear, no discharge, globes and pupils equal. You're checking for strabismus or nystagmus, and the eyelids are where things get tricky.
Entropion versus ectropion.
Right. Entropion, the eyelid rolls inward, causes severe corneal damage from the eyelashes. But ectropion, where the lower lid droops outward, is actually deemed normal in certain breeds.
Here's where it gets really interesting. I mean, think about that wild contradiction. Ectropion creates a literal catch basin for dust and debris, setting off chronic conjunctivitis. But because of a breed standard, it's considered normal.
If we connect this to the bigger picture, this is the delicate balance a vet student will have to strike. You're caught between respecting breed standards and advocating for the structural health and welfare of the animal.
It's a tough spot to be in.
It is. You have to manage the normal defect clinically, educating the owner on daily care to prevent chronic pathology.
Wow. Okay, rounding out the head, you check the ears. They need to be clean and odor-free. Ear mites are super common at this age and need prompt treatment.
Definitely.
After assessing the head, the exam moves inward to the core and outward to the coat. We're listening and feeling for hidden defects now.
Starting with the chest. Lung auscultation. No abnormal sounds, obviously. But the heart, and this is vital, you must auscultate on both sides over the entire cardiac area.
Right, to catch murmurs that might suggest congenital heart defects. If you only listen to one side, you might miss a patent ductus arteriosus.
Exactly. Then you move to abdomen palpation. If you feel a distinct thickening of the intestines and there are no other GI signs, that strongly suggests a significant worm burden.
Just packed with parasites.
Unfortunately, yes. You're also checking for hernias. Umbilical hernias are very common. Inguinal hernias are less common but harder to detect.
So let me see if I had this straight. An umbilical hernia is kind of like a minor dent in the car bumper that we can fix at the next service appointment. But an inguinal hernia is more like a tricky chassis issue we need to monitor closely.
That's a perfect analogy. Clinical decision-making isn't just about finding the problem, it's knowing when to intervene. An umbilical hernia is rarely urgent. You can defer it until the vaccine course is done or roll it into a routine spay.
Because you're already in there.
Right. But an inguinal hernia carries a higher risk of complications and should be repaired when the animal is mature.
Got it. And while you're down there on male patients, you're checking for cryptorchidism.
Yes. Small animal testicles are hard to palpate at this age, but if they haven't descended, it's a serious defect, especially for animals meant for showing or breeding.
Okay, moving to the skeletal system and skin. Chondrodystrophic or giant breeds are really tough to evaluate at this age.
Very tough. You rely heavily on assessing their symmetry from the front and rear. And then for the skin, pruritus itching is incredibly common.
Scratching themselves raw.
Yeah, but here's the thing. It's normally caused by ectoparasites. Allergic skin disease is actually uncommon at this age.
Right, because their immune systems haven't had enough exposure to develop environmental allergies yet.
Exactly. Look for the bugs first.
Okay, so the physical exam is done. They have a clean bill of health, or at least a managed care plan. Now we arrive at the final, most crucial preventative step of the consultation, building their immune shield.
The vaccination protocols, let's break it down. For dogs, we use DHP distemper, hepatitis or adenovirus, and parvovirus plus lepto-4.
And the schedule for that is at 8 weeks, 12 weeks, and 1 year, right?
Correct. And for ongoing boosters, the DHP is given every 3 years, but the lepto-4 requires an annual booster.
What about cats?
Feline schedule targets FPV panleukopenia, FHV1 herpes, and FCV calicivirus, given as fellow V plus tricat at 8 weeks, 12 weeks, and 1 year.
And the boosters for cats get a little specific. It's Ducat for year 1 and year 2, and then back to Fellow V plus Tricat for year 3.
Exactly. Now, amidst all these complex protocols, there's a pro tip that makes a massive difference.
Oh, I love this part.
When giving the vaccination, use liver paste on the stainless steel table to distract the puppies and kittens.
I mean, this is the ultimate vet student cheat code. It's a brilliant piece of practical magic.
It really is, because it brings the entire narrative full circle. The very first goal we discussed was making the clinical examination a pleasurable experience.
Right. Overriding the pinch of the needle with an incredibly high-value snack. Cementing that positive association for a lifetime.
Exactly. They remember the treat, not the shot.
So what does this all mean? For you, the vet student listening to this, mastering this routine isn't just about memorizing facts or, vaccine schedules. It's about building a structured, confident approach to every new life that walks into your future clinic. From the history gathering, the nuanced nose-to-tail exam, right down to the liver paste distraction.
It's a huge responsibility. And it raises an important question to think about as you continue your studies. As the popularity of designer breeds with extreme characteristics continues to rise, how will your definition of a normal clinical exam have to evolve in the next 10 years of your career? Are we, as a profession, going to have to redefine what healthy looks like?
Man, that is a heavy, fascinating thought to leave on. Keep digging into your sources, keep questioning the baseline, and thank you for joining us on this deep dive. See you next time.